Good evening, everyone. So, as always, we are in another episode of our webinar. It's a joint webinar today by the ISCCM and ESOI, the Also Society of India, which is titled Hope Lives On, essentially a tribute to the master and the father of the ECMO program, Dr. Robert Bartlett. Robert Bartlett. As you all know, he unfortunately passed away in the 20th of October. And I think his work, his research has really changed the way we would look at certain patients who would have probably otherwise not survived. I think, as you know, the journey of ECMO is something probably we'll be talking about. So without wasting much time, I have a very esteemed set of panelists today. I think it's an honor to actually lead this entire group of stalwarts of ECMO. Many of them have been closely associated with Dr. Bartlett and are pioneers of the ECMO program in India. So we will start with, I would also like to welcome all my esteemed guest lecture panelists and all the resource persons and all the delegates who are joined today, and also my co-panelist, Dr. Shika. I'd also like to thank the entire ISCCM and the ESOI leadership for making this possible. And we will start with a video message, with a video montage of Dr. Bartlett, a tribute to his work. Chirag, can you please play the video? Thank you.
We were on vacation and Jay got sick. We weren't sure what it was. And when we got back, we went to the emergency room and he was diagnosed with what was called impressive pneumonia. He was in the ER, but then immediately taken to the ICU. After about 2 weeks in the ICU, he developed ARDS. And as a result, the doctors thought that he needed ECMO in order to survive. And he was on ECMO for 10 days, which saved his life. Jay, for many of them, and the nurses too, was the miracle. Like the fact that he got better and could walk into the ICU months later and say hi to everybody blew people's minds at that time. Without Dr. Bartlett, there is no ECMO. And without him, there is no Jay.
And I think the thing that really struck me in the hospital that I tried to answer is how do you tell somebody thank you for saving your life? In the case of ECMO, because it was so early, because there was a lot of varied opinions about its success, and therefore not as much access at the time, for Elizabeth and myself, we wanted to basically provide that opportunity for other people. Whether that be talking to other patients that were considering ECMO at the hospital, we actually talked to patients at the hospital, funding, in the early days. That was our way of actually providing that opportunity for other people. You say thank you all you want, but the real way to thank these caregivers is to provide that opportunity for other folks and allow them to have the same chance, or maybe a better chance than I had.
Bob has achieved an amazing amount with what he's done, but a true leader creates leaders. And he's created numerous leaders, not just the medics, not just the scientists, not just the respiratory therapists at Allied Health, but this whole army of people committed to the cause. How brilliant he is with his inventions, the fact that he's created 20,000 other people means that his legacy will live way after that brilliant singing voice departs.
So we've got a number of different tunes here, so we'll start with Amazing Grace, how sweet.
What are we most proud of? It's really about those students and residents and scientists who've resulted from working in our lab. And, I'll get a letter about every week from a student who was in the lab 10 years before, 12 years before, now is doing something valuable in medicine or perhaps in biomedical research. So that's the rewarding part. Teaching and mentoring is really what it's all about.
There are more than 3,500 patients in the registry who have been treated for pulmonary emboli, and the majority have survived to hospital discharge. So I think we can say that Dr. Gibbons' challenge is fulfilled.
Dr. Gross was the chief of surgery at Boston Children's and the father of all of pediatric surgery, a remarkable man, arguably the most important surgeon of the last century. His role in ECMO was simply to be encouraging to me. So I said, Dr. Gross, we ought to build a membrane oxygenator and see if it would allow us to use the heart-lung machine for longer time period. He said, yeah, that's a good idea. Why don't you do it? And I always say I've been working on it ever since. From my personal point of view, he's responsible for me getting involved in this particular field that became known as ECMO. So whenever we have a gathering, a dinner or a meeting or whatever it is of ECMO people, we always begin it with a toast. Here's to the memory of Robert E. Gross, without whom none of us would be here.
Thank you. So next on today's event, we have a lecture from by Dr. Poonam Malhotra Kapoor. I'm Dr. Poonam. Of course, all of you know ma'am. I think she doesn't need any introduction. Big name in the ESOI, big name in the India's ECMO journey. Ma'am will be talking on about Dr. Bartlett's life, and also about his compassion and vision, which I think we briefly saw in the opening video. Just a remembrance about his entire journey. Ma'am, over to you for the next 15 minutes. Ma'am, please take over the dais, please. Thank you.
Thank you. I'm at the airport and I would like to dedicate not just today, but the rest of our journey from India as a part of SWAC also, as a part of ECMO Society of India, as a part of the Simulation Society, as a part of AIMS, or any institution wherever we all work. ECMO today is because of our mentor, our forefather, Dr. Robert Bartlett. I met him in 2010, and I would like to speak a few things through this video. I would request Sandeep to play the video for me since I'm at the airport. So as we could see towards the end is online. Not come last 2 meetings to attend, and that is ill health. We will have the lecture. We'll have the live. Good evening, everyone. I dedicate this editorial in the 10th volume of the Journal of Cardiac Critical Care to the father of ECMO, Dr. Robert Oz Bartlett. This father of ECMO, who not only founded ECMO along with his colleagues, but he dedicated his life to revolutionizing the critical care medicine. From premature infants to elderly patients with heart or lung failure, his innovations today have offered countless individuals a second chance at life. Today, ECMO stands tall as a standard of care worldwide, a testament to his futuristic vision, perseverance, and pioneering spirit. Dr. Bartlett's journey began as a surgical resident at Peter Ben Brigham and Children's Hospital, where he was encouraged by Robert E. Gross to improve the artificial membrane lung. Embracing this challenge, he devoted decades to refining ECMO technology. In 1989, he founded the Extracorporeal Life Support Organization, ELSO, of which we are all so many of us Indians today, members with more than 27 centers from India dedicated to Southwest Asian ELSO, a global chapter of ELSO. This global platform that promotes research, collaboration, and training in ECMO stands tall today with a ELSO registry record of over 1 lakh lives saved, a 50% of mortality and 50% of the 2 lakh people in the recent Joseph Turner's registry, which he so well did with so many other ELSO members, stands a testament of the times that ECMO, from a mortality of 70%, today has a mortality of only 50%. Dr. Bartlett, who was an academic trailblazer, earned his medical degree with honors from the University of Michigan and completed a distinguished surgical residency, holding leadership roles such as Chief President in Thoracic Surgery and various fellowships at the Harvard Medical School. In 1970, he joined the University of California, Irvine, where he treated the first adult ECMO patient in 1971 and the first neonatal patient in 1975, a baby 50 years old today, fondly named Esperanza, meaning hope, by the nurses and symbolizing the optimism that ECMO brings to patients and families worldwide. In 1980, Dr. Bartlett returned to the University of Michigan, establishing the ECLS Research Laboratory and expanding ECMO programs to serve patients of all ages. Through ELSO, he nurtured a global community of clinicians and researchers advancing both clinical practice and technological innovations. His achievements were recognized with numerous prestigious awards, including honors from the American College of Surgeons, the Society of Critical Care Medicine, and international surgical societies. Beyond his professional accomplishments, Dr. Bartlett was a compassionate mentor, educator, and humanist. He freely shared his innovations, believing that medical progress should benefit humanity rather than personal gain. Outside the hospital, he pursued music, sailing, and hockey, enjoying life with his wife Wanda and 3 children. Dr. Robert leaves behind a remarkable legacy of intellect, of compassion, and life-saving innovation that will continue to inspire physicians and caregivers around the world to enhance the patient's life and outcomes with ECMO. I dedicate, as the chief editor of the Journal of Cardiac Critical Care, a well-indexed journal today, along with our associate editors and our chief mentor, Dr. Yatin Mehta, to Dr. Robert Bartlett. This also brings about not just an editorial by me, but wishes from Dr. Mehta, as well as a beautiful editorial by the ELSO community shareholders today. The board, chiefly led by Christine Stead and Peter Rikers. Their editorial stands tall in this beautiful write-up that they have dedicated to the father of ECMO, Robert H. Bartlett. May his legacy live on to infinity is my wish. Thank you ISCCM and thank you ECMO Society of India for giving me this opportunity. It's good to be a good Indian and be a part of the ELSO community today. I urge all of you to become ELSO members, to create centers in your ECMO institutions as ELSO centers, and not just that, let's all together enhance the outcomes on ECMO.
Thank you,
I would
ma'am.
just like to say, Sunil, without Dr. Robert Bartlett, ECMO will live on, but the spirit of ECMO would be lighted from the heavens above. We'll miss him.
Yes.
Especially all of us who worked with him and were inspired by him. Thank you.
Truly, ma'am. Thank you, ma'am. Thank you for such a wonderful lecture and throwing light to what he has stood for and what he has transformed for patient care. And as you rightly said, made a paradigm shift in critical care for those patients who probably would have otherwise not even survived. So thank you, ma'am, and thank you for sparing your time in spite of your busy schedule and putting all that effort, sitting even at the airport and being able to join in. Thank you for all that, ma'am. Thank you very much. So we'll move on to the next lecture. Dr. Pranay Ojha sir will be talking on the ECMO journey. Largely about the scientific milestones, the registry itself, the impact it has created, and how ECMO has been globally adapted after the initial work by Dr. Bartlett and onwards, how things have actually evolved. Sir, over to you for the next few minutes, sir.
Thank you, Sunil. Can I share my slides?
Chirag?
Yes, sir.
Yeah. No, sir, slides, please.
Yeah, I'm just sharing my slides.
Okay.
I hope you can see my slides.
Yes, sir.
Okay.
Yes, sir. All good, sir.
Yes, so next 15 minutes, I'll just take you through the ECMO journey, the scientific milestones, and the ELSO registry. Okay. So ECMO started first with an CPB. Right from 1635, people have started working on it, and they conceptualized the notion of an oxygenator. In 19th century, the role of oxygenator and blood perfusion, that was well identified by the various people, and people have realized that the need of extracorporeal oxygenator and extracorporeal circulation. Okay. It is moved further in 1900 from the just an idea to a proof of concept, and the few development which has taken place which helped to develop an CPB and ECMO program is the blood group and the discovery of heparin that was been done by J. McLean. Okay, and then the first in 1929. The first auto injector was formed, that was an extracorporeal perfusion of the dog, which was done in Russia. After that, moving from that in 1930 to 1950, people has worked a lot on development of CPB. And in that case, Gibbon was the one who has been very successful in doing that. And he has first performed in 1939. CPB is on cat, and then he has moved on. And in 1953, he has done a first successful ASD closure with the CPB machine, and it was where the patient remained on CPB for almost an hour or so. These are the different works which have been done by the stalwart from 19th century. okay, of right from the idea of sustaining the function of an organ is an artificial perfusion. Okay. And after the CPBS formed the stone for the ECMO to come into, and from 1971, the first ECMO case has been done. But before that, the people started working on the oxygenator, especially the first work was on a bubble oxygenator and then the silicone oxygenator. And probably the things has changed with the silicone oxygenator. And it was remain as a standard of oxygenator for a number of years as an FDA approval oxygenator only for ECMO, and that remained for almost till the end of the 19th, around 20th century. And from either after 2000, probably the PMP oxygenator started into the picture, come into the picture. So the clinical case was done first in 1971 by Donald Head, and it was the first ECMO which was survived, and it was an RTA. Okay, who develops motor vehicle accident, and then he develops a ARDS, and he was put on ECMO, and he successfully came out of ECMO. Okay. 1972, Bartlett has done a pediatric ECMO, and in 1975 he has done a neonatal ECMO, and after that the things has changed. Another big name in the field of extracorporeal circulation in the field of pulmonology is Gatinonin, whom we lost few months back. He has also done a lot of work, and he was started working on an ECOR since 1978, and he has published his paper in 1986 and 89 about the ECOR. Okay. There's some drawback in the ECMO trial runs by NIH trial in 1979, and probably that trial was suggestive of that ECMO is not of much use in adult patients. Okay, but and that's why probably the adult ECMO work halted at that stage, and probably more and more pediatric and neonatal ECMO was still going on. 1980 to 1990, it was basically an era of neonatal and pediatric ECMO, and there was a development of dual lumen cannulas. And in 1999, the ESOI was formed by Dr. Robert Bartlett. Okay. From 1990 onwards, people started working on PMP oxygenator, and almost from 1990 to 2000, by the end of the 21st century, probably all the ECMO was converted to a PMP oxygenator and centrifugal pump. Okay. This is John Gibbon, who is working on a CPB. Okay, that was his first experiment in 1939 on cats. And then this is Dr. Lilly, who has worked on bubble oxygenator. But there was a lot of problems with the bubble oxygenator, including the thrombocytopenia, coagulopathy, hemolysis, edema, and organ failure. And that's why the next oxygenator which has come up was a silicone oxygenator, which was a work by Colbo and Japol. So they worked on silicone oxygenator, and this remained as an ECMO oxygenator for at least 2 decades, where it has been used as an ECMO oxygenator. Even, in fact, we also have used this silicone oxygenator in 2006 to 2010. Okay. This is the first case. Most of you must be knowing this picture of a patient on ECMO. You can see the large circuit, the large oxygenator which was there. Okay. This was the first auto injector which was there. And this, I think all of us know, in 1975, the first neonatal ECMO was Esperanza. And you can see she has grown up to, this is a picture of her when she was 26 years. And now she's, I think Poonam has shown a picture where she was 50 years old. So you can see how things has gone. Coming to the landmark trials, NIH trial is one of the landmark trial, but that was a negative trial for an ECMO that was done in mid-70s. It was a national multi-center trial. The problem with this trial is it was terminated prematurely. Only 30 cases were registered. There was 9 centers were was doing this center, and after only 3 centers were trained in the experience with an ECMO point. All patients, even with the respiratory ECMO, they are put on VA ECMO. There's high heparinization, anticoagulation levels very high, and I think that's the reason a lot of patients develop bleeding, and the survival, there's no benefit of survival. And that's why it was concluded that ECMO is not for adult ARDS patients. Swanberg worked on the double lumen cannula in 1986, and gradually double lumen cannula is getting importance, and now even people has moved from double lumen cannula to a VA RAPA cannula, so the drainage from the RA and return it back to the pulmonary artery. and that's good for right heart failure and even for the good for the ARDS patient also, because the recirculation chances goes to zero. Okay. Dr. Bartlett has done a lot of work on it. He started working on this, it's right from in the early 70s or before that. And basically, as he says by himself, that he was being, inspired by Dr. Ghosh. When he was taking around with Dr. Ghosh, he said that can we do something to improvise the oxygenator? And as the right mentor goes, say, why don't you work on it? And probably he has taken up a challenge and he started working on that. And that has made a lot of difference in the field of ECMO. Okay. And this is how the ECMO centers and ECMO lab work from of the Bartlett from 1975 to 1990, where he developed his ELSO at the end of 1989. He made the ELSO society, ELSO as an organization. And this was the first meeting which took place in the October 1989 at Michigan University on the ELSO, the first meeting of ELSO. And from 2000 onwards, there are a lot of development that takes place in the ECMO. First, the adult ECMO were developed because of two reasons. One is H1N1 that has come up in 2009. And there are a lot of centers have done ECMO. There are a lot of papers by Australia and New Zealand registry. And at the same time, the Caesar trial came from the UK, which shows that ECMO is definitely of a benefit in adult patients, not only in terms of surviving the life, but also in terms of, a cost-effective ECMO. Okay, that is what it says. And then the 2010 to 2019, and now in fact still onwards, we are getting ECMO as a much advanced. The number of indications are increasing. We are started thinking of heparin-free ECMO, awake and mobilization of ECMO in that. Another kick which ECMO got, and especially in India, is the COVID pandemic, where the number of centers are increased, and almost the centers number in India has become double than what the centers number were before the ECMO was. Okay. So from 1960 to 2010, there's a prolonged extracorporeal circulation work was going on. That heart, lung, and rest and kidney rest concept has started developing in that area, and the different generations and translational research which has taken place in developing these extracorporeal therapies. This is about the Caesar trial, where almost around 180 patients was recruited. Out of that, 90 patients was supported with an ECMO, and they have 63% survival as compared to the 47% survival in the conventional group. And that concluded that definitely there is added advantage of ECMO in ARDS patients. Next comes an Eolia trial that was done in 2018. Again, that trial was not as successful as what they was expected. The basically trial was made with an intention by Helen Scrum that he tried to prove that ECMO is definitely superior and can be a first line of treatment in ARDS as compared to a ventilator. But then, unfortunately, statistically, he could not prove that. Definitely, the survival in case of ECMO was definitely better than the survival in case of only conventional ventilator, but it was not statistically significant. Again, there were a lot of drawbacks in that trials also. And finally, it was concluded that the ECMO should be considered only when the prone position is fails after that. This is a work on Getinonin in 1986, where he published about low flow VV ECMO, and he talked about extracorporeal carbon dioxide removal, not only in the COPD patient, but also in the patient with the moderate to severe ARDS patient, where CO2 is a predominantly factor. He tried to dissociate the CO2 removal and oxygenation, both the things. So CO2 removal can be taken care of with the extracorporeal circuit, and oxygen can be taken care with the help of low ventilations. Okay, so we try to keep the respiratory rate as low as possible with the high PEEP and low minute ventilation. We try to maintain the oxygenation. And there was a supernova trial which was positive, but later on there was not much benefit in a severe ARDS. So ECOR again could not get much of its name in the severe ARDS, but it get persistent been used in case of acute exacerbation of COPD and with the good results. Okay, this is how the journey occurred. That is what I already discussed about it. Okay, so the journey of ECMO is from experimental science to a perfect science. Previously, in fact, even when we started ECMO program in India in 2007 to 2010, people used to say it's an experimental science, but now it has been beyond proved. More than 1 lakh person has been saved because of ECMO per se. Okay. It is a journey from the last resource to a choice of modality. And most of you must have seen during COVID time, people started talking about using ECMO even before putting the patient on ventilator because they know that they cannot be managed on ventilator. So it was once upon a time it was the last resource, and now it becomes a choice of modality. Many patients nowadays are being just supported on ECMO for procedural support. So for airway bridges, airway diseases, or for the protected PTCA and protective surgeries. So it has been started using as a, and ECMO started from VA ECMO. It was the only modality when in 1971, but then it has moved from VA ECMO to VV ECMO to double lumen cannulas, from ECO, and then now hybrid ECMOs. And ECMO has become more and more safe practice in ECMOs like heparin-free ECMO and awake ECMO. Newer indications are started doing previously what was thought to be a contraindication, even like sepsis and septic shock, they have been started considering as an ECMO indications. So the work of Dr. Bartlett when he started in 1989 ELSO, and then after that he started 4 chapters of ELSO, that is Euro ELSO, Asia Pacific chapter, and Latin American chapters. And the last chapter what was started was SWAC ELSO, and we are fortunate enough to be a part of it when the Steve Cornard and Peter came to Mumbai, and we started initiating the talk of SWAC ELSO somewhere in 2000. Started 2011, we started talking about it, and probably we conceptualized it in 2013, and we had our first conference in 2014. So 2010, we had done the first conference of ECMO in India, and then we invited Steve, and they were kind enough to come, and we started talking about developing a SWAC ELSO chapter. Okay, and that's a huge, biggest chapter of the ELSO. Okay. ELSO is doing a lot of work in education, and they started with the certification course on adult and pediatric certification course, and they are doing a lot of courses which are ELSO endorsed course. So they are mainly into ELSO is mainly into education, publication, lot of publications right from the first Red Book to the 6th edition of Red Book and training manuals. Now at present there is a 5th training manual which is going on. And it has got a huge source of data registry. Okay, so they have a huge source of data registry. The number of ECMO centers gradually increase, and it is now more than 600 centers of ECMO in across the in the ELSO. And there are almost around 20,000 cases to 25,000 cases getting registered, almost roughly around 22,000 cases getting registered every year in the ELSO data. Okay. So out of 2,45,000, almost 1,33,000 patients survived and they have been went home. And this is the data across the globe. Okay. And you can see the that in last 10 years, the data is 1,06,000 patients was done in last 10 years only. Okay. This is the volume of the cases that is coming from the different chapters of the ELSO. The North America, the Latin America, most of the cases have been done in North America and Europe. And then comes the Asia Pacific, then comes the SWAC ELSO, and last is the Latin America. And you can see how the ECMO cases evolve. If you see in 1990s, you can see mainly the neonatal and pediatric cases, and then gradually the neonatal and pediatric volume started going down to baseline, and the adult patient ECMO number cases are started going up, especially after 2009 with the H1N1 epidemic and the Caesar trial. Okay, these are the different ECMO centers which are registered with ELSO all throughout the world. And this is how the ELSO has progressed. Once it's been established in 1989, they started developing a registry in 1990. And then they kept on improvising their registry. So then they have started with doing a cardiac addendum. So CPR addendum they have added into. And then they have done H1N1, and lastly they have done a COVID addendum and severity score addendum. So then we can get all the statistics from the ELSO registry. It's a huge registry that. And ELSO registry helps in many ways. One of the way it helps is it helps the industry for the pre and post market surveys, and they don't give data to the registry to the industry, but then take plan of the industry, and they analyze the data for them and they submit the data to them. So what is going to be more helpful and what is probably the future research solution for that? Data registry has been even used for a clinical research also. From 2017, almost more than 800 proposals has come as for the ELSO data registry, and out of that 400 proposals approved. And you can see the number of ELSO registry publications has keep on increasing, and it is almost around 30 35 cases per year since last 2 years. In 2022, definitely it has gone up to 50, but otherwise it remains on 30 to 35 publications every year. That comes only from the ELSO registry data. Okay. ELSO registry helps to develop the centers by doing benchmarking and it gives you quality reporting. So they analyze the data. If your center is submitting the data, they analyze the data of your centers and they compare the data with an overall ELSO registry and with the higher centers or with the centers which has closely your numbers of per year cases, and they compare that data with you and they send the data to you, and that helps to know that where you are standing and probably where you need to improvise yourself. Okay. It also helps and telling about the complication rate and comparing the complication rate with the ELSO data and with the centers which are doing similar number of cases per year. And then comes the journey of ECMO Society of India, where we have started in 2010 with the mission of promoting the ECMO in India. Okay, the first done thing which we have done is in 2010, we started the conference on ECMO and in the Riddhi Vinayak Hospital, Mumbai. Because 27th and 28th November was the first day where first conference took place in Mumbai in Hotel Holiday. Now we have got more than 800 members in the ECMO Society of India with an institute of membership around 190. Okay, and then we are running a lot of programs, the annual programs and workshop and fellowship programs. The challenges what we faced in India initially was huge patient load, and in fact we are also facing now also. So there are a lot of patients who needs ECMO. The cost is an issue. The manpower is an issue because we don't have that much enough manpower who can manage this number of load what we have. The problem is the transport because the cost is going to be involved and availability of the disposables because there's nothing in Make in India. And to that solution, we found that if we increase the number of centers who are doing ECMO, probably we can able to take care of higher volumes. Okay. And that's why we require to train more people in the manpower. And that's why when we started the ELSO endorsed course, one course in a year, then we are gradually increased now. And now we are doing almost 4 courses in a year. And we are training almost on 250 to 300 delegates every year. Okay. To take care of transport problems and shifting the patient, we started an outreach program and we been to different centers and we started managing the patients in different centers. And many of the centers, I'll say almost 50% of the centers where I started ECMO program, they are now independently doing their ECMO per se. This is how the clinical roadmap of ECMO has gone from 1990s to 2024. It started with as a pediatric cardiac surgical program in 2 of the prime institute like AIMS and Narayan Rudyalaya. And gradually in 2006, we started with an ECMO in ICU program, initially as a cardiac, and then we have been to cardiac and respiratory also. 2010, we started the mobile ECMO unit, and then it keep on getting added as a transplant, poisoning, where Vivek has done a lot of work and he remained as a pioneer in ECMO in poisoning, especially in the northern part of India. And then H1N1 has definitely increased the number of centers in India. And then lastly, the COVID, which has definitely doubled up the number of ECMO centers in India. This is how the academic training, which has gone throughout India, right from 2010, the first book of ECMO and the first conference on ECMO. And then gradually we have increased the number of training courses. We have published another books. We have initiated academic wing where we started training the people from fellowship and certificate course. And now we have a different state branch, almost 12 state branch we have now. And we have started with the research wing also. Okay. So this is research wing in India. And luckily, we started even with getting some data from Indian data. In the last time, last year data that shows around 600 patients of ECMO was being registered with us, and almost around 40 to 41% survival in these cases. This is purely an Indian data in that way. There are different ESOI activities, as I told you about the publications. We have started the Indian Journal of ECMO, newsletters, different courses which we are running, and we have our YouTube channels, Facebook, and that. Okay, and we are working on the guidelines to come up with the different guidelines which takes place in India. Okay, so this is about the training course, and as I told you, we are doing almost 4 training courses in years, and almost we got delegates from coming from all over India, except whatever you can see the red marks. We didn't get the delegates coming from that area, but almost around 98% of the part from India, we are getting the delegates from that, mainly coming as an intensivist to develop. We started working on developing an Indian product also for manufacturing, so that the cost can come down and the availability of the ECMO equipment is still under the process, and probably in next year 2026 we should be able to come out with that. There are 2 programs which we are working actively on. That is developing an ECPR program in India, and we are at the phase 2 of ECPR program, where we are working on a clinical implementation of ISCA. And then probably the next 2 stages is remaining in future is certification and clinical implementation of this program. And I'm getting help by Ram, Rodrigo from out of India, and Dipenjan, Vivek. They are also helping me in this project. Okay. And the project we have started is a outreach program, so we can go to the Tier 2 and Tier 3 cities, where we can locate which institute can develop an ECMO program, and we'll try to help them to develop an ECMO program with the remote help. And we are at the phase 1 of this program. We just finished with the phase 1. We are going to start with the phase 2 of this program. This is how we are going to, there is a plan of remote ECMO program. So with a local partnership, and we have the state branch basically developed with that intention, so that we can go to the remote place in different states, and we can do ECMO management, and then we can have an e-ECMO program where the central hub and regional hub can control the patients at the periphery. A lot of works going on with an ELSO collaborations, like we are a part of a global education committee, train the trainer. Okay, we are asking for the Indian separate data and research oriented and clinical work. We are associated with them. I am associated right now with Dr. Roberto Luroso with a postcardial cardiogenic shock. And then they want still more people, more of our team gets associated with them for a clinical and transnational research. Okay. I will end my talk with what Robert Bartlett humbly said is, it's easy to look back and think that there was a brilliant plan, but it wasn't that at all. We started out to solve a problem, and then another, and then another. We just persisted and sticking with the problem until it was solved. With a big team of people, with some phenomenal researchers trying to keep people alive who were going to die. That's it. Thank you. Thank you for giving me an opportunity.
Thank you, sir. Thank you for such an inspiring lecture and showing us the path of ECMO, both historically, both from the world's perspective and as well as the Indian journey, which you and your institute has really pioneered. Next online will be Dr. Arpan Chakraborty. I think all of us know his passion for ECMO. I think every time I meet him as well, he just inspires us to go on and do more of ECMOs. Dr. Arpan will be talking on reflections of ECMO, the role of mentorship and a humanitarian outlook to the same. Dr. Arpan, over to you, please.
Thank you, Sunil, for such a wonderful program. And I'm sharing my talk. Reflections of ECMO with the mentorship and humanity. I took some time to understand what I should talk about this thing. And then I found this is it visible, no? My thing is visible?
Yes, Dr. Arpan.
Yeah,
please
fine.
go.
So, it's about exploring the balance between technology and teaching and compassion. I must confess that I have never met Dr. Bartlett, but I have heard his name many a time, and I have felt I should know him, and I have seen the legacies are very much within us as ESOI mentors. So a mentor is remembered in every success and probably in every failure, and even in not performed cases. Even if you say no to an ECMO, a mentorship is needed. So we know ECMO is more than a machine. It's an advanced life support bridging life and death. And it's a beyond physiology human story is written. And it's always a team sport. It needs a lot of people. It needs resilience. As Dr. Pranay Ojha has told, it is because it's only the persistence and probably a trust, a three-way trust between a doctor and a patient and the patient relatives. So it defines outcomes. And ultimately, what it happens, that what family is thinking about the ECMO after the first counseling. So this is the thing where your success of your mentorship, your program lies on. Because whenever you are telling that a patient of you, your patient is going to die or not see the next day's sun, probably with an 80% probability, and here the ECMO is going to rescue for that night, how the family is thinking about that. This is the way we should think about ECMO working in our day-to-day ICU practice. Now, coming to the humanity part, we are actually connecting the science and the soul. A flowing blood in the circuit, and an ECMO transforms a body, both the body and the caregivers. So here the numbers meet the narratives. What is the P, delta P denotes? What does a SpO2 denotes? What does a P1 denotes? So it meets the narratives, and compassions are always with that, how you can the target that those numbers to a level of perfection. And healing is both physiological and emotional in part of that. So we have to remember, even if you have to put two bigger pipes, slightly bigger than the central venous lines, but it is actually giving a healing beyond the oxygenation. So keep mind, you should be mindful that when you are putting the ECMO, you are not only ensuring the oxygenation, you are actually promotes the healing of a bad lung, healing of a bad heart, or healing of a bad capillaries. So this meets the science and the soul when you are practicing ECMO. Now, coming to the mentorship, what is a mentor should do? Mentorship is nothing but a lifeline. It's a silent lifeline. Somebody is, I have kept my screen blurred because I know some Pranay Ojha or some Venkat Goyal is just behind me when I'm performing something. So who is Dr. Robert Bartlett? And how he is going to be alive even after his demise on 20th October. So somebody of us, somebody of one of us has to take the lead. So every ECMO case is a classroom, and mentors shapes the skill and the values. You should be answerable to every ECMO cases to your mentor. And the thing should be the mentor is looking after you, even they are invisible. So true mentorship asks, what do you think? This patient should get a VV or VA. This patient should be added a cytosorb in the circuit or not. Will you wait for the next dialysis for 24 hours or to give it now? Every question should be asked as if an invisible mentor is behind you. And it builds humility, confidence, and ethical judgment. So we promote the guidance, not the hierarchy. Now, coming to humanity amidst the machinery, the patient is just surrounded by machines. Just now, I have one patient who are connected with 6 machines, starting from ventilator, from ECMO to inhaled nitric oxide, everything add on. It's 6 number of machines has been connected. Hardly you see the patient. This is only a 4-year-old child. But what it is doing, it's circuit that sustains life, but empathy sustains the hope. Machines are oxygenating the blood, not the spirit. So patient, we should not call it an ECMO case. It's more than a case. It's a technology plus touch is equal to the healing. So we intervene with empathy. Even if you cannulate, a touch of empathy should be with you. Now, coming to the moral weight of the ECMO, the ethics, when to start, when to stop, a mentor is needed over there. No algorithm replaces moral reasoning. That's why not any RCT has been proved hopeful, because you cannot do RCTs on a moribund patients. We know, all of us. And mentorship guides you uncertainties. When you are uncertain at 12 o'clock the midnight, well, whether I'll put the patient on ECMO and will it be successful? The patient will see the next day 6 o'clock in the morning. So here the mentorship guides you, and integrity and empathy define the expertise. So the mentorship is the guidance beyond the guidelines. And what are you going to listen beyond the ICU? Reflection is integral to growth. Every survivor teaches gratitude. Every loss teaches you humility. Mentorship and humanity remains our compass. So collective wisdom from your success and your failure, and a shared humanity from your failure and from the failed patients. So closing reflection, ECMO is extracorporeal mentorship and humanity. It blends science with compassion, leading by example, learning and empathy, healing through both hands and the heart. So who taught you the ECMO? The ultimate guidance would be your patients. Every patient is teaching how to do better things in the next patient. And when a mentor is needed, why a mentor is needed in ECMO? Because of limited evidence. Even after 50 years of successful ECMO, you have not a big RCT which is going to tell you that you should put the patient on ECMO with a 90% outcome. You have a resource constraints. You have resource allocations are going to be high cost and labor intensive. So you are not, even if you want, you cannot do ECMO in every cases. End of life care, a patient had a brain dead on ECMO, how we are going to do that? Moral distress, even if you fail, what are you going to do with the nurses? What are you going to with the doctors? So you should know this, how you are going to tackle them. And patient and the family experiences, if they are good, even they are good, how they are going to be good after the discharge. Will he be able to join his previous work with the same fitness? If he died, who is going to take care of his family, and how we are going to how we are going to just see the economic breakdown they have happened. So all these things need a mentorship, a silent mentorship just behind that. So mentorship plus humanity is just when a physiology meets philosophy, and your survival, your patient survival meets the soul. So respect your survivors. They are the major, better guide, better mentors for your practice, and be a part of their life. So thanking you again and closing my talk.
Thank you, Dr. Arpan. Very well-rounded and summarized talk. I think the gist of which, of course, as you rightly put it, the right blend of technology, of a physician as a clinician, and of course, empathy. I think which probably I would fully agree with you that ECMO is the epitome of amalgamation of all these characters, which is very much what we do in critical care as well. Thank you, sir. I think after this, from the journey of Dr. Bartlett, the journey of ECMO in India, I think we will now come to what is the future of ECMO. We'll have a very esteemed panel led by Dr. Venkatraman Kola, who will be moderating the session on AI portability and the future outreach of ECMO, essentially looking at what the future is going to hold. Dr. Venkat, on to you. And I know we have just sort of exceeded the time, but I'm sure Dr. Venkat is a master of conducting webinars, as you all know, and I'm sure he will keep it short, sweet, and end it quickly. I'll allow you to introduce your panel, Dr. Venkat, and take it forward from there.
Yeah, thank you, Dr. Sunil and the ISCCM and ESOI Society. And yes, I think in the next 15-20 minutes, we will try to wind up things. I first of all try to invite 4 of my panelists who have been seasoned clinicians in the field of ECMO. They don't need any introduction. I request Dr. Venkat Goyal sir, Dr. Sandeep Devan, Dr. Vivek Gupta sir, and Dr. Vinod Singh sir to be on board. I think all of them are there already. Can you hear me, sir?
Yeah.
I can hear.
You're audible.
Yeah. So the couple of weeks to a month back, when I was in the Washington DC attending the ELSO Congress, I was seeing a big cutout of Dr. Bartlett. I never knew that in a month time we will come to hear that he is no more with us. His memories will only be there. So dedicating this today's discussion in the memory of Dr. Bartlett, I probably will start this. The topic given was the future of ECMO. And the three words which they define is artificial intelligence, 1. Second, portability. Third is outreach. I think those 3 words will be the key in future of ECMO. To start with, I request Dr. Venkat Goyal sir, the evolution of ECMO over the last decade. In our medical school days, from the early part of the H1N1 pandemic, we saw this as a last resort life-saving therapy in patients with severe ARDS. To now we are talking about it's an organized life support strategies in a very extensive group of patients, including, as we were talking about, procedural, say high-risk procedures. Where do you see, sir? Where are we in a real-world scenario? Have we moved from those last resort therapy to a organized strategy, or it is only confined to a very few centers? Dr. Venkat Goyal?
Yes, sir. I
Yes.
feel that ECMO is till date in India is confined to very few centers just because of the cost constraint, and the quality of work of ECMO at these few centers are also not up to international standards, because again the decision to start ECMO is late, and again the patient condition is already reached into multidisciplinary or multi-system involvement. So we are still quite behind the international scenario of doing a good and effective ECMO in time and in quality.
Okay. Hello, can you hear us, sir? Sir, there was a voice break. So you mean to say that there is a lack of uniformity, there is lack of still a uniform standard across the all the parts of the India where ECMO is initiated?
Since in India the health is a self-funded affair, where there's hardly any contribution from the national resources, or in terms of unlimited resources even for insured people, we are unable to use this modality wide and loud. So therefore, the people who are real in need of this technology or these services are not able to receive this service, point number 1. Then second, by the time they are a candidate for ECMO, they don't reach the right center, because I feel the right center for ECMO are very few, because the volume of work that should be there to achieve a level of excellence is not there in most of the places. And thirdly, the time factor, even if they reach the center there, again, logistics and delay in decision making, they all contribute to substandard work. So if we want to promote ECMO in our country, we have to tailor-made ECMO according to our Indian economy, and then only we will be able to have a volume of work. If I say it is similar to a ventilator application of ICU patient, previously putting the patient on ventilator was just a dream to district level hospitals also. Means I remember when I was a registrar in my MD days in Jaipur, a complete state of Rajasthan, where all spinal injury patients could not be given a ventilator because there were hardly one ventilator in the entire 2000 bedded hospital in Rajasthan in the year 1989. So
Dr.
that
Just we will again come back as you are very rightly mentioning about the outreach, the availability outreach. We will have it as a last segment of it. But you made a clear point key at this point of time, even though we have a ECMO programs in many centers, there is a lack of standardization, uniformity, and probably it's a double side of a coin. We are talking about inexperiency, volume. The other side, they also keep debating if we don't start, we don't do, we don't get that experience. But you said there has to be some standardized regulatory, maybe a methods, then only it can come. But my other question to you is, do you think we still moved out from a rescue therapy to a organized life support? Most of the centers, as you said, are not still there. Most of the times it is again still used as a part of a rescue therapy where ventilation failed, but it's still not as available as a direct organized life support therapy at this point of time, except maybe a very few tertiary centers. Do you agree with that, or you have any different opinion?
I agree with that because even for simple things, we don't use it as per scientific guidelines or standards. We are using things only as the last resort for even smaller modalities like dialysis or other things or CRRT. So ECMO is a much costlier application, and we are only using it as a rescue therapy, and most of the time we are late in that.
Yes. So cost and other constraints are playing their role. So we are still using a last resort. I think we are still not there to use it as a standard organizing life support. Coming back to the second part of the question to Dr. Sandeep Devan, do we have Dr. Sandeep Devan there?
I think Dr. Sandeep is not here, Dr. Venkat.
So probably you can take this question, sir, Dr. Vinod Singh, sir. Portability is again another issue. As Dr. Arpan was just mentioning, in the initial years when I was seeing a ECMO machine, there's so many cables, so many wires, so many things. If now you see a latest version ECMO machine, the portability, the ease has been manifold. And that made it possible to transport this ECMO patient in ease, in not only just in ambulances, airs, or to cath labs, to OTs, to many things. Do you think that portability is helping and it will be a way forward if we get a portable, very compact ECMO machines with all the circuits, cables come in a very portable way? Dr. Vinod.
Yeah, if you look at Dr. Venkat in the last 10 years, the portability has changed. Okay. So now we are having more portable machine. This can be run on the ambulances. The machine can be run on the ward. That can be run on the bedside also. But still we need, there is some problem in portability also because the machine battery backup is only 2.5 hours. Maybe some machines have got 2 hours battery backup. So it is not possible to go for a long transport of those patients unless and until you have the ambulance with such a backup that you can run the ventilator, you can run all the monitors, and then you also have to run the ECMO machine. So we need a more and more battery backup in such machine. That's one thing is required. And again, the circuit is problem, and this is a long circuit, and this is the serious portability. The portability is not the issue in the hospital because now we are running the ECMO machine in the bedside. Like in the previous 10 years back or 15 years back, if you want to start ECMO, then the patient has to go to the operation theater somewhere where the ECMO machine is there. Now the ECMO machine can go to the bedside. So this is the major achievement in the portability, and not only the portability, the safety also. We are having more and more safer ECMO that can actually detect and actually correct the things also. You can do the intervention in the newer machines, like getting a new machine, CPR, air bubble, and anything that the machine is getting alarm and all those things. So that a lot of changes has occurred, and in future, the ECMO machine is going to be more and more portable. What we are looking is that in the near future, it is quite possible that we can have a home ECMO, we can have a chronic support ECMO that can be run at the home also. Those patients who are waiting for lung transplant and those patients who are waiting for the heart transplant. So this is, I think, this issue has been resolved, and gradually it is going to be resolved.
Thank you, Dr. Vinod Singh, sir. Dr. Vivek Gupta, you will be the right person to answer this. We all understand portable ECMO is probably the way forward to go. But what makes us to probably the logistical barrier, cost barrier, other barriers to use them in India? We already had a glimpse from Goel sir. We need something, and from Moja sir that we need something to have a better outreach of this. So what do you think that which is preventing us from this portability of it?
That's really a good question. Actually, in a context of India, as Dr. Vinod rightly pointed out, that on one end, the miniaturization of circuit, advancement of technology, safe ECMO transportation, these things are feasible. But still, we have a challenge. Because if you look at the Indian scenario, we have the diversified medical systems. On one end, you have everything available in the hospital. You have all modalities, all equipments, and on the other hand, when you go to the I will not say the remotest area, but even in the some hospital in the tier 2 cities or tier 3 cities, you will not find anything, and that really becomes a big challenge from infrastructure wise. I'll give you a few example of that. You have a ECMO machine with you, you want to transport, your team is well trained for that, but think when you reach to that hospital, you don't have the another oxygen outlet which you can connect, because one is connected with the ventilator and the other oxygen outlet is not there where you can connect it. Or pressure, you don't have these compressed air systems to use that. Or even I go lower than that. You need 8 or 10 connections for the electricity, and they are looking for that. Okay, we need an extension board so that we can provide you this electricity. So these are the real challenges, practical challenges, if we really try to transport these patients from one hospital to the other hospital. Even if you plan to go to the other hospital and we do it. So these are the infrastructural issues. Is still many ambulances are not well equipped to transport until it's a good ECMO center who is ready to transport these patients. So there are many, but yes, over a period of time, we have overcome the challenges and we have proven it that we can transport or we can do these mobile ECMOs. Gradually, our learning curve is increasing. Second issue is the manpower, because you have only few trained people are there with the ECMO. You don't have a very big team, and they are also busy with their other clinical work. So that is another challenge, that who will go and who will transport the patients, who will do it for it. So you need a bigger team, bigger experience of the people. Another big challenge which I'm seeing in our country is the infection control practices, very poor in ICU, in spite of lot of efforts. And just imagine when patient is being transported, or we have gone to the other organization and to do, how much compromise will be there. And it is going to affect our outcome directly. Okay. And already Dr. Venkat and Dr. Vinod both have highlighted the cost issue. That yes, the therapy is very costly and it becomes very challenging to bring down the cost when you are transporting. Then railway is, even if it has a very good network, but still it is not of any use for us, at least for transporting these patients. So road ambulances, road transport, or air transport. Air transport is too costly. So up to 300, 400 we can manage with this, but that becomes a very challenging when you think about the air ambulances and you are spending 15 lakhs or 18 lakh, 20 lakh rupees just for transporting the patient. So that's burden, because we do not have a government support, or there is no national strategy. Then you have a challenges when you are transporting these patients, you landed up with the jam. So there is no help that way. So these are the some common issues which during these portable ECMO we face practical issues.
Thank you, Dr.
Yeah.
Vivek.
Dr.
I think,
Venkat, I think we try to keep it a little
yeah,
brief. Yeah, try to finish over
try
the
to
next
keep
3-4
it
minutes.
one more questions each and
Yeah.
maybe a precise one.
Yeah.
Coming back to you, Venkat Goyal sir, you spoke about outreach availability. You already have a simulation center with multidisciplinary training. Where do you see your future for this outreach from the metro cities, Tier 1 cities to different parts? I could see Dr. Oja presenting you training all over India except maybe 1 or 2%. So, what is your goal? What do you think that affects your outreach?
Till education, it is a very good idea, and because now all intensivists have an inclination towards an ECMO learning, so outreach program definitely makes it available to different states and different hospitals. So training very good, but standards and giving good results and having a positive outcome will depend upon the quality of services.
So your Indianized Simulation Center, the multidisciplinary training, you reaching out to different parts of the India, giving training has been phenomenal. Hats up to you, sir. A quick question to Vinod Singh, sir, related to the artificial intelligence role. So do you think, like in other parts of artificial intelligence, does it plays a role in ECMO? You already hinted that it actually picks up some of those air bubbles or some other complications there. Do you think that will going to help us in decision making and even predicting our outcomes? Vinod Singh, sir.
AI is going to have the major impact on the ECMO because it is a complex technology and there are multiple machineries there. So one of the most important thing which is going to be helped to intensivists is the indications. At present, actually, if you look at the indications, there is not a very good supported data for those indications. So if you have a AI predictive indications of the ECMO, who are the patient, now we have put the data and then you will find out whether the patient is fit candidate for ECMO or not, depending upon the ventilator days and all the primary disease and all those things. So AI will give you, I think, the best solution for the indication. And second is that if the AI is equipped with the things that we can auto-regulate the ECMO support, like if the patient has got hypoxemia, the flow should increase. If the patient has got a better weaning prediction by the AI, and also the mortality, who are the patient who is the primary problem is not going to be resolved. If the AI can predict, and in the future it is going to be predicted by AI model, so the AI is going to have a great impact on the ECMO in the future. Maybe next 5 years, the AI will take many decision making in the ECMO.
Okay, the last question to Dr. Vivek Gupta, sir, do you think in India we are working in a public hospital with a very cost-effective way? You can be mentoring many outreach such models across India, and in future that networking in a distant monitoring and guidances can make a difference in a scalable way in the future.
Yeah, I fully agree that it has to be a multimodal and in a fashion of hand holding. So it cannot be done by just one method. We can, though it is a very easy to say, but difficult to is a challenging, difficult to implement. That is spoke and hub model. But because majorly the ECMO is done in the private sector, so it needs more of the integration and trust on the different hospitals because they are from the different. It's not all the government hospitals. So, but yes, that one model, if we make that one center who is doing a good number of ECMO, it's the ECMO center, and other centers are referring them, and they are integrated with each other. Probably that will help us to improve the patient outcome, as well as more and more number of patients will be getting ECMO help. Moreover, different way of training program, because the biggest challenge we face is the physicians who are not aware about the ECMO. So when the family, as a family physician, some patients attendant is asking about ECMO, they are negative about it. So creating awareness probably is one of the very big things. Training intensivists, because intensivists are the first line clinicians who really can be helpful in identifying these patients early, because most of the time all of us have seen that we are being called as a last resort, and that by this time it is too late to initiate ECMO. So integrating with telecommunication, teleconsultation, hand holding with as the ECMO Society of India is doing, that we have the WhatsApp group, or we are ready to get a call from anyone who needs, who is running ECMO and having some challenges. So all these can be helpful for developing and progressing the ECMO in our country. But these small scale things will be really helpful and will really make a change in the system.
Thank you, sir. Over to you, Sunil
Yeah.
Karan, sir.
Thank you, Dr. Venkat, and the entire esteemed panelists. I think I'm sure we would have wanted to go on for quite a bit of time, because ECMO itself is such a fascinating topic, and I think the future definitely looks bright. Though we could argue that the literature in terms of the quality of evidence is not very, very strong, but I think all of us who have been doing ECMO, we can swear by it to say that it has really changed and made a paradigm shift in the last decade. So at the end of it all, thank you all my esteemed panelists. Thank you to the ISCCM and the ELSO and the ESOI for being able to make this joint webinar. And I also would like to thank the leadership of ISCCM for facilitating this. Once again, thank you all for spending a valuable time of your Friday evening here. Thanks, Dr. Venkat, for putting up the questions and guiding all of us. Thank you.
Thank you very
one
much.
and all. Yeah.
Good night.